Topic is kidney renal system. The study of kidney diseases is facilitated by dividing them into those that affect the four basic morphology components. These components are glomeruli, tubules, interstitium, and blood vessels. This approach is very useful because the early manifestations of disease affecting each of these components tend to be distinct. Hence, we have to divide the symptoms of renal disorders under following four headings. Further, some components seem to be more vulnerable to specific forms of renal injury. For example, most glomerular diseases are immunologically mediated. Most glomerular diseases are immunologically mediated, whereas tubular and interstitial disorders are frequently caused by toxic or infectious agents. Some disorders affect more than one structure, and the anatomic and functional interdependence of the components of the kidney means that damage to one usually secondarily affects the other. The clinical manifestations of renal diseases. Number one, azotemia. Azotemia is defined as a biochemical abnormality that refers to an elevation of blood urea nitrogen, also known as BUN, and creatinine levels, and is related largely to a decreased glomerular filtration rate. The term azotemia is feature of both acute kidney injury as well as of chronic kidney injury. There are two types of azotemia. The number one is pre-renal azotemia and the second is post-renal azotemia. First we will discuss about pre-renal azotemia. It is encountered when there is hypoperfusion of the kidneys. There is hypoperfusion of the kidneys that impairs renal function in the absence of parenchymal damage. It may be caused by number one, hypotension, excessive fluid losses from any cause, or if the effective intravascular volume is decreased due to shock or volume depletion or congestive heart failure or cirrhosis of the liver. These are the causes. Second is post-renal azotemia. It is seen whenever urine flow is obstructed and the flow is obstructed distal to the kidney. Relief of the obstruction. Whenever the obstruction is relieved, it is followed by correction of azotemia. When azotemia leads to clinical signs and symptoms associated with biochemical abnormalities. When azotemia leads to clinical signs and symptoms associated with biochemical abnormalities, it is termed as uremia. Uremia is characterized not only by failure of renal excretory function, but also by a host of metabolic as well as endocrine alterations. These results from renal damage. Nephrotic syndrome. It is a clinical entity caused by inflammatory glomerular disease and is dominated by the acute onset of either grossly visible hematuria, that is presence of red blood cells in urine or microscopic hematuria defined as more than 4 RBCs per high power field when examined under microscope with dysmorphic red cells and red cell casts on urine analysis. Diminished GFR, mild to moderate proteinuria and hypertension. The second entity is Nephrotic Syndrome. It is also due to glomerular disease. Nephrotic syndrome is characterized by, very important, heavy proteinuria, defined as more than, that is, excretion of more than 3.5 gram of the protein per day. Second is hypoalbuminemia, followed by severe edema, hyperlipidemia, and lipidemia. These are the characteristic features of nephrotic syndrome. Acute kidney injury. This term is previously called as acute renal failure. The acute kidney injury is characterized by rapid decline in glomerular filtration rate within hours to days with concurrent dysregulation of fluid and electrolyte balance and retention of metabolic waste products normally excreted by the kidney, including urea and creatinine. Chronic kidney disease, previously termed as or called as chronic renal failure. Chronic kidney disease is defined as the presence of a diminished glomerular filtration rate, which is defined as persistently less than 60 ml per minute per 1.73 meter square of the body area, meter square of the surface area of body for at least 3 months from any cause and or persistent albuminuria. This is chronic kidney disease. Now we will discuss structure of the glomerulus in brief. Many clinical manifestations of glomerular diseases result from perturbations of specific components of the glomerular duct. The glomerulus consists of an anastomosing network of capillaries lined by, these capillaries are lined by fenestrated endothelium invested by 2 layers of epithelial cells. The visceral epithelial cells, these visceral epithelial cells are commonly referred to as porocytes, are incorporated into and become an intrinsic part of the capillary wall, separated from endothelial cells by a basement membrane. The parietal epithelium, second part, the parietal epithelium situated on the Bowman capsule lines the urinary space, the cavity in which plasma filtrate first collects. The visceral epithelial cell is important for the maintenance of glomerular barrier function. Its slit diaphragm presents a size-selective distal diffusion barrier to the filtration of proteins, and this type is largely responsible under normal circumstances for the synthesis of nothing but GBM components, that is glomerular basement membrane components. Pathologic responses of the glomerulus to injury. Number one response is hypercellularity, characterized by increase in number of cells in the glomerular tufts. The hypercellularity results from A. Proliferation of mesangial or endothelial cells. B. Infiltration of leukocytes. And last is formation of crescents. These are accumulations of cells composed of proliferating glomerular epithelial cells and infiltrating leukocytes. Number two is basement membrane thickening. By light microscopy, this change appears as thickening of the capillary walls, best seen sections that are stained with per iodic acid shift, that is PAS. Number third is hyalinosis. What is hyalinosis? Hyalinosis is applied to glomerulus, denotes the accumulation of material that is homogeneous and eosinophilic by light microscopy. Next, hyalinosis. Next response is next is sclerosis. Sorry, not hyalinosis, sclerosis. Sclerosis is characterized by deposition of extracellular collagenous matrix. It may be confined to mesangial areas, as is often the case in diabetic glomerulosclerosis, in all the capillary loops or both. Now we will discuss about the pathogenesis of glomerular injury. The exact mechanism of glomerular injury is not very clear, but immune mechanisms underlie most forms of primarily glomerulopathy and many secondary glomerular disorders. Two forms of antibody associated injury have been established. Number one is injury by antibodies reacting in situ within the glomerulus, either binding to insoluble fixed intrinsic glomerular antigens or extrinsic molecules planted within the glomerulus. Injury resulting from deposition of circulating antigen antibody complexes in the glomerulus. Diseases caused by in situ formation of immune complexes. In this form of injury, immune complexes are formed locally by antibodies that react with intrinsic tissue antigens or with extrinsic planted antigens in the glomerulus from the circulation. The pattern of immune deposition by fluorescence microscopy is granular, reflecting the very localized antigen-antibody interaction. Membranous nephropathy is the classic example of this example, that is in situ formation of immune complex. In anti-GBM antibody induced glomerulonephritis, antibodies bind to intrinsic antigens homogeneously distributed along the entire length of the GBM, it resulting in diffuse linear pattern of staining for the antibodies by immunofluorescence techniques. Glomerulonephritis resulting from deposition of circulating complexes. In this type of nephritis, glomerular injury is caused by the trapping of circulating antigen antibody complexes within glomeruli. The antibodies have no immunologic specificity for glomerular constituents. The antigens that trigger the formation of circulating RT complex may be of either endogenous origin or exogenous origin. Endogenous origin is in the glomerulonephritis associated with systemic lupus erythematosus, SLE, or in IgA nephropathy, also known as Berger disease. They may be exogenous, as may occur in the glomerulonephritis that follows certain infections. Another important mechanism of glomerular injury apart from immune-mediated diseases is cell-mediated injury. In this mechanism, sensitized T cells cause glomerular injury and are involved in the progression of some glomerulonephritis. Mechanisms of progression in glomerular diseases. The outcome of such injury depends on several factors, including the severity of renal damage, the nature and persistence of the antigens, and the immune status, age, and genetic predisposition of host. The two major histologic characteristics of such progressive renal damage are glomerulosclerosis and tubulointerstitial fibrosis. Edema in nephrotic syndrome is usually mild. Acute nephrotic syndrome. The hematuria is generally slight, giving the urine smoky appearance, and erythrocytes are detectable by microscopy or by chemical testing for hemoglobin. Appearance of red cell casts is another classical feature of acute nephrotic syndrome. The proteinuria is mild as compared to nephrotic syndrome, where the proteinuria in protein more than 3.5 gram per day. Here, the proteinuria is mild and the cutoff is 33. Sorry, the criteria is less than 3 gram per 24 hours and is usually non-selective. That is nephrotic and proteinuria. Hypertension is variable depending upon the severity of the glomerular disease, but is generally mild. Edema in nephrotic syndrome is usually mild and results from sodium and water retention, which is one of the pathogenetic feature. Oliguria is variable and reflects the severity of glomerular involvement. Nephrotic syndrome, heavy proteinuria. That is loss of protein more than 3 gram per day or per 24 hours is the chief characteristic feature of nephrotic syndrome. That is nephrotic range proteinuria. One is nephrotic range proteinuria less than 3 gram per day. This is the nephrotic range proteinuria more than 3 gram per day. Hypoalbuminemia is a product primarily consequent to urinary loss of albumin and partly due to increased renal metabolism and inadequate hepatic synthesis of albumin. Often, The plasma albumin level is 1 to 3 grams per deciliter. Normal 3.5 to 5.5 gram per deciliter, and there is reversed albumin globulin ratio. Edema in nephrotic syndrome appears due to fall in the colloid osmotic pressure consequent upon hypoalbuminemia. Sodium and water retention further contribute to edema. Hyperlipidemia is a frequent accompaniment of nephrotic syndrome. It is hypothesized that the liver faced with the stress of massive protein synthesis in response to heavy renal protein loss also causes increased synthesis of lactose. Lipiduria. It occurs following hyperlipidemia due to excessive leakiness of glomerular filtration barrier. Hypercoagulability. Patients with nephrotic syndrome may develop spontaneous arterial or venous thrombosis, renal thrombosis, and the pulmonary embolism due to various factors. These include increased rate loss of antithrombin 3, hyperfibrinogenemia from increased synthesis in the liver, decreased fibrinolysis, increased fractionation, and protein C and protein S. Acute post-streptococcal glomerulonephritis, that is acute PSGN. As the name implies, this cluster of diseases is characterized histologically by diffuse proliferation of glomerular cells associated with influx, or rather we can say exudation of lymphocytes, typically caused by immune complexes. It is common form of glomerulonephritis or acute glomerulonephritis in developing countries, mostly affecting children between 2 to 14 years of age. But 10% cases are seen in adults which are above 40 years of age. The onset of disease is generally sudden. After 1 to 2 weeks of streptococcus infection, most frequently occurs through. Particularly, nephrogenic are types 1, 2, 4, 12, 4, 1, and red lack of group A beta hemolytic streptococcus. My bad. Particularly nephrogenic are types 12, 4, 1, and red streptococcus. And red lack of group A beta hemolytic streptococcus. Patients that supports the immunological basis of PSGN are points that supports the immunological basis of PSGN are the latent period between infection and onset of nephritis is compatible with the time required for the production of antibodies and the formation of immune complexes. Elevated titers of antibodies against one or more streptococcal antigens are present. Last but not the least, there is hypocomplementemia. Now we will discuss about the morphology or the gross features in case of PSGN. The kidneys are symmetrically enlarged, okay, weighing 1.5 to twice the normal weight. The cortical as well as sectioned surface show petechial hemorrhages, giving the characteristic appearance of pre-bitten kidney. Microscopy. We describe microscopy under 4 headings: glomeruli, tubules, interstitium, and blood vessels. Microscopy. The glomeruli are affected diffusely. They are enlarged and hypercellular. The diffuse hypercellularity of the tuft is due to proliferation of mesangial endothelial cells, endothelial and occasionally epithelial cells, acute proliferative lesions, as well as by infiltration of leukocytes, that is chiefly of the neutrophils. Tubular changes are not very striking. There may be swelling and hyaline droplets in the tubular cells. In interstitium, there is edema as well as leukocytic infiltration. About 1/3 cases of acute glomerulonephritis are caused by organisms other than the hemolytic Staphylococcus. And these organisms include other bacteria. Example, Staphylococci, Pneumococci, Meningococci, Salmonella, and Pseudomonas. Some viruses, example, hepatitis B virus, mumps, infectious mononucleosis, and varicella. Parasitic infections include malaria, toxoplasmosis, and schistosomiasis. Next is crescentic or rapidly progressive glomerulonephritis, also known as RPGN. RPGN is a clinical syndrome associated with severe glomerular injury, but it does not denote a specific etiology. It is characterized by relatively rapid and progressive loss of renal function associated with severe oliguria and signs of nephrotic syndrome. If untreated, death from renal failure may occur within weeks to months. The most common histologic picture is the presence of crescents in most of the glomeruli, hence the name crescentic glomerulonephritis. Crescents are formed from the proliferation of parietal epithelial cells lining Bowman's capsule with contribution from visceral epithelial cells and the invading mononuclear cells. The stimulus for crescent formation appears to be the presence of fibrin in the capsule space. RPGN occurs most frequently in adults with slight male predominance. Crescentic glomerulonephritis is divided into 3 groups on the basis of immunologic findings. Anti-GBM antibody mediated disease characterized by linear deposits of IgG and in many cases C3 in the glomerular basement membrane. The example is Wood-Pasture syndrome, diseases caused by immune complex deposition with granular deposits of antibodies and complement by immunofluorescence. Lupus examples are lupus nephritis, IgA nephropathy, and Hanoch-Spondyl purpura. Positive immune crescentic glomerulonephritis is defined by the lack of detectable anti-GBM antibodies or immune complexes by immunofluorescence and electron microscopy. Example is Wegener granulomatosis. Following 3 serological markers are used for categorizing RPGN. Number 1 is serum, complement 3, C3 levels, anti-glomerular basement membrane antibody, that is anti-GBM antibody, anti-neutrophil cytoplasmic antibody, that is ANCA,